Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton Hellman, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. July 16th, 10 a.m. Eastern Standard Time. That's when tickets for the online International EM Cases Summit go on sale. The summit's going to be November 21st to 23rd, 2024. This is the best, most interactive, most educational, most rejuvenating virtual EM conference in the world. Space is limited for the symposiums on ED flow, rural EM, and global EM. Space is limited for the Heart's ECG course with Jesse McLaren, and also limited for the small group simulations with Sarah Fooey. Head on over to emcasessummit.com to grab your tickets. Your ticket will include an ebook summarizing the talks, 3 days access to all the talks and procedural demos, plus access to all the speakers to ask any clinical questions that you might have, and a chance to connect with EM providers worldwide. All right, now on to pediatric meningitis. You hear an overhead call to your ED resuscitation room. As you enter the room, you see a toddler who looks sick. They're drowsy, pale, and mottled. You look up at the cardiac monitor and you see a heart rate of 160, a respiratory rate of 42, oxygen saturation of 96% on room air. There's no obvious signs of respiratory distress, and the nurse tells you the temperature is 38.5 degrees Celsius. The mother of the child then tells you that her child has had a cough and cold with a fever for the last 4 days or so, and just a few hours ago became drowsy, which prompted her to bring them to the emergency department. Intake has been poor, a few less wet diapers than usual, no vomiting, normal bowel movements, no rash. There's no recent travel history, no sick contacts, no past medical history. The child's fully immunized. Mom has been giving the child ibuprofen for fever with pretty good effect. A quick initial physical exam reveals a GCS of about 10, cap refill of 3 seconds, normal muscle tone, no signs of head injury or bruising elsewhere, a bit of intercostal indrawing, but no other real signs of respiratory distress, clear ears, clear chest, benign belly, and no rash. You ask for a BP, and it's within normal limits. Cap glucose is normal. You ask for a peripheral IV to be placed, and as you do so, the child vomits. We're going to stop there in the case and introduce our two guest experts on this podcast, who are Dr. Shannon McPhee and Dr. Jeanette Comeau. These are new to EM cases. They were recommended by Trek. We have a few podcasts that we've arranged through a collaboration with Trek, and we're very pleased to have you on the podcast. First, Dr. McPhee, could you give us a little bit of background about how you ended up being an all-star emergency pediatric physician?
Thanks, Anton. I don't know about the all-star part, but I'm originally from Halifax, Nova Scotia, and I did pediatrics and a pediatric emergency fellowship at the Hospital for Sick Children in Toronto. And since I finished that in 2005, I've been back at home at the IWK Health Centre and Dalhousie University in Halifax, Nova Scotia.
Fantastic. And I understand you were the chief of the emergency department?
Yeah, I had the opportunity to work as the departmental chief for almost a decade. And I've also done a lot of work over the years with translating emergency knowledge for kids, or TREC as we say.
All right. And obviously humble as well. All right. And Dr. Comeau, could you tell us a little bit about your professional background?
Sure. So like Shannon, I am from Halifax. I did my pediatric infectious disease training at McGill. And then I spent a year in Sydney, Australia with the National Centre for Immunization Research and Surveillance, doing some additional training in vaccinology before coming home in 2017 to Halifax and the IWK Health Centre.
Wow, interesting. So we've got an infectious disease specialist and a pediatric emergency specialist to talk about pediatric meningitis, which can often be a challenge, whether you're an adult general community physician, an academic physician, or a pediatric emergency physician, these kids can definitely be a challenge. So I want to go back to the case here. Again, we've got this toddler who looks pretty sick. Their cap refill is 3 seconds. They're mottled. Their SAT is okay. On exam, there's not too much to find that's specific. Dr. McPhee, just generally speaking, how are you going to manage this sick kid?
Just the way that you've presented things, this kid does worry me. And anytime I'm in that zone of being a bit worried, I'm going to take it back to the basics. And so I'm going to go through my ABCs to start with. And so we'll make sure that the kid is capable of protecting their airway. It sounds like breathing is fine. I may apply some oxygen, so 10 to 15 liters by a face mask, just because you're giving me the sense that there's sort of some poor perfusion. And then we're going to stop a bit on circulation. I'm not happy at all with that heart rate of 160. And so for a toddler, I would define a critical heart rate as anything above 145. So that's got my attention right there. We're seeing signs of poor end organ perfusion. So we've got a cap refill of 3 seconds. The kid's mottled. Kid's level of alertness is down. So this is a kid I'm really worried about. And my priority at this point is getting vascular access, which you say I've already gotten. And I'm going to start with a 20 mil per kilo normal saline bolus, knowing that I may have to repeat that with careful observation in between. But even in the back of my mind thinking, gee, is this a kid that's going to need some inotrope support later on? So kind of having all of my backup things in there. And one of the things that I liked about how you presented things is you completed the DEFG, or don't ever forget the glucose, which is really, really important in a small patient who can often use up their stores pretty quickly. And so happy for now that that's good and stable, but it might be something that I need to circle back to later on.
Excellent. Okay, so what are you thinking in terms of the diagnosis so far in this case?
At this early in the game, I know the kid's sick. I'm worried about a severe sepsis sort of picture with the critical heart rate, the signs of perfusion. I'm really starting to think a lot about the information that you've given me, that this kid was okay, seemingly for a few days with what sounds like a viral illness. And then suddenly, within a matter of hours, the kid's deteriorating. And for me, that sounds really worrisome. It makes me really worried about a secondary bacterial infection. And that could come from absolutely anywhere. So this kid needs to be looked at from head to toe, including the possibility of a meningitis. But at this stage, I'm going to have to do a very detailed physical exam. And I think that some labs also would be indicated at this moment, just to give me a sense of what I might be dealing with.
All right, fair enough. So let's say you stabilize a child, you've got oxygen on, you've given them a bolus, you're thinking about antibiotics. You go back and do a detailed head-to-toe exam, and when you try and lift the child's head off the stretcher, their neck feels pretty stiff. Now you're worried about meningitis. So before we get into exactly how you're going to manage this patient and all the details of meningitis, I want to get a sense of the pathophysiology of meningitis and what meningitis actually is, because there can be a viral meningitis, there can be a bacterial meningitis, there's encephalitis, which is sometimes associated with meningitis, but is also a distinct, different disease. We all know that meningitis is inflammation of the meninges, but Dr. Comeau, could you tell us, besides the inflammation of the meninges, what's happening from a pathophysiologic perspective when a child gets meningitis?
Sure. To back it up, I'll start with sort of the beginning of how meningitis can occur. And there's sort of 4 main steps that lead up to invasion of the bacteria into the meninges or the CSF space. So it begins, in fact, with the pathogen colonizing the mucous membranes. So you can have colonization of bacteria in either the respiratory, GI, or GU tract. Often we would think about the respiratory tract or the oropharynx as being the main place that you would harbor bacteria that can then go on to cause meningitis. And just because you're colonized, that's a common phenomenon, doesn't mean that you're going to get to step number 2. Step number 2 is invasion of the bloodstream. So that's when we see the bacteria cross through the mucosal epithelium and enter into the bloodstream. And that can actually occur by a number of different factors, including environmental factors And even reflecting on this case, we heard that the child likely had a viral infection and was seeming to look a little bit better. And that's a really classic thing that we would see in pediatric meningitis. Other risk factors can be things like smoking or exposure to smoke or even alcohol abuse in older individuals. We also can have invasion of the bloodstream by host factors. So, in children or persons with inborn errors of immunity or acquired immunodeficiency, either HIV or by treatments or a diagnosis leading to immune suppression. So, we've been colonized with the bacteria, and then the bacteria has invaded into the bloodstream. The next thing the bacteria needs to do is survive intravascularly. And this is usually something intrinsic to the pathogen itself. And so you've heard about encapsulated bacteria, which is able to evade some of the bactericidal effects of the immune system. So complement, for example, allows for the bacteria to survive in the bloodstream and then ultimately get to the site of meningeal invasion. And so that's when the bacteria actually penetrate into the subarachnoid space. And this is really facilitated by the duration of bacteremia and the degree of bacteremia. And so you see an interaction between the bacteria and the epithelial cells of the blood CSF barrier, allowing invasion to occur. Once invasion occurs, then we have really an inadequate humoral immunity in the CSF space itself, which allows bacteria to multiply and propagate within the CSF space. And in so doing, we see that we can have elevation of the intracranial pressure through leukocyte recruitment, vascular degeneration, vasculitis, and vessel occlusion within the CSF space. In a nutshell, we have somebody who's colonized, somebody who has the ability to have that colonization from mucosal go into the bloodstream. The bloodstream facilitates invasion across the meninges, and we get replication of bacteria in the CSF space. When we think about that mechanism, we think about the common bacteria, and the common bacteria that can lead to meningitis are those encapsulated bacteria, which includes bacteria like Streptococcus pneumoniae or Neisseria meningitidis in the older child and adolescent. And then in the neonates, we know that the most common etiology will still be group B strep and E. coli. And that's because when we think about what the neonate is colonized with, it's group B strep and E. coli, given that they've recently come through the vaginal canal during parturition.
Those are actually really important details to even just to help remember the bugs and to really understand what's going on. And then in addition to that, to understand there's this whole inflammatory cascade that's going on, which ties into, why we give steroids and then which antibiotics we're giving and why. And it's just a lot easier to remember what to do in these patients when you understand exactly what's going on, what we're trying to stop in terms of the pathophysiological process. Let's move on to the big question that I think is probably the most important one, is when to suspect pediatric meningitis. We see lots and lots and lots of kids with fever. We see lots and lots of kids with headache. We see some kids with neck stiffness and neck pain. And, we know that fever, headache, and neck stiffness is, of course, the classic triad of meningitis, but it's only seen in less than half of meningitis cases. And of course, the younger you are, the harder it is to elicit these symptoms or signs. And meningitis is actually pretty rare. I think the numbers are something like 0.4 per 100,000 teenagers and 81 per 100,000 infants under 2 months of age. So it's more common in neonates, less common the older you get. And the older you get, it is pretty darn rare. So this is why it's also difficult to know when to suspect it. We don't want to be LPing every kid with a fever who looks like they might have something more than the common cold. So the big question is, when should we suspect meningitis? Let's start with infants, where it's probably the most challenging because of their atypical presentations. Dr. McPhee, when do we suspect pediatric meningitis in less than 90 days old?
Those babies under 3 months are for sure our most challenging population. It's really difficult to trust the physical exam, and developmentally, these kids just can't tell you what's bothering them or can't really localize things very well. And so they're a population that we worry a lot about. But to start, I would say that a change in temperature is often a key. And I've chosen those words carefully because I'm worried about kids with a fever, which is a temperature that's higher than 38 rectally, but I'm equally worried about a young baby with a temperature under 36. And so paying close attention to those babies with hypothermia is really critical. And in fact, some of the sickest patients I've looked after are the young neonates with hypothermia. So definitely something to keep on your radar. Outside of that, kids with young infants like this with meningitis have very non-specific signs and symptoms, and often the presenting complaint on triage will be something like not feeding well or some vomiting would be pretty classic. And you're right, it would be really hard to do a lumbar puncture on every single one of those. And so I'm going to really zero in on some of the neurological symptoms. And in a really young baby, that could be lethargy. It could be irritability and seizures. And many parents come into the Emerge and they complain that their child is irritable. And irritable to me as a pediatric Emerge doc means something a little bit different. So it means a baby that's crying and is not soothed by their caregiver. It may denote a really high-pitched cry. And I think what's specific about the irritability that we see in neonatal meningitis is that it's actually worse when they're in their parents' arms. And so they're babies that often like to be left alone. And so that should be a really big red flag for you if you're looking after a baby that looks like that.
All right, fantastic. So hypothermia, don't forget that hypothermia is often worse than a fever, and that might indicate that they have meningitis. And neurosymptoms, I love that pearl, that, the inconsolable pearl of when they're in their parents' arms, that's when they're even more inconsolable and they like to be left alone. And then the high-pitched cry is another key pearl there. My understanding is that nuchal rigidity almost never happens in these little infants. Could you comment on that in terms of your own experience? I tend to just, for every kid who has a fever where it's not immediately obvious that it's a simple viral infection, I check their neck. But could you just give us some practical advice on how to check the neck, how to interpret it, and if there's any sort of pitfalls and pearls in checking for nuchal rigidity?
Yeah, so Anton, back in the older days, checking for meningismus was called the pediatric handshake, right? So that was at a time when the incidence of meningitis was much higher. There was probably a bigger pickup rate on that. With the young kids, if you are assuming that every child that you see with meningitis is going to have a stiff neck, you're going to be missing out, and you're going to be missing out in that diagnosis. And so it's just something that's not as accurate as we like in those really young infants that are less than 90 days. I would say the other clinical pearl is probably around the examination for a fontanelle. And so checking for a bulging fontanelle is an important part of your physical exam when you're worried about meningitis. And it's important that the detail is done right. And so if you're looking for a bulging fontanelle, the baby needs to be in a bit of a sitting or being held in an upright position to really check that. And that's something that I find that many young practitioners aren't accustomed to doing. And so a really important detail.
In terms of checking for a bulging fontanelle, the two key things, I suppose, are waiting until they are consoled, and having them in an upright position is also a great little pearl. All right, so that's a bit about the challenges of when to suspect meningitis in the infant. How about older children, say a 4-year-old or a 12-year-old? When would you suspect meningitis in a child or in a teenager?
I think you talked a little bit before about that classic triad of fever, headache, and neck pain only being present in 50% of kids with meningitis. And so even if a kid just has 1 or 2 of those symptoms, I would seriously consider meningitis on my differential. I think the most worrisome clinical finding would be a spreading petechial rash in any age group, but in particular in the older kids. And just going back to where the young infants, I would really be concerned about a bulging fontanelle, any kind of meningeal signs such as neck stiffness, and a history of seizures outside of that typical febrile seizure range.
All right, great. And what about Kernig and Brzezinski sign? I know in the adult population, Kernig and Brzezinski signs have kind of been tossed out as not very useful. What about in kids?
I think in pediatrics, we're looking at the same thing. And so the sensitivity of those tests ranges anywhere between 50 to 65%. And so not a very reliable test in this circumstance. And so they have often followed by the wayside.
Okay, fantastic. And Dr. Camo, do you have any tips and tricks about clinical clues that would heighten your suspicion for meningitis in either the infant or the older child? Anything to add there?
I think Dr. McPhee covered it quite thoroughly. The one thing I might add, and certainly my background in vaccinology would perhaps give away my likelihood to comment on this, is that it's really important in pediatrics to get a good immunization history. And if immunizations are incomplete, then children are at a higher risk of having Neisseria meningitidis, Streptococcus pneumonia, or Haemophilus influenza causing bacterial meningitis. I would also say, though, that because of immunizations, we have seen a decrease overall in the incidence of meningitis. And I think in part, that's why this podcast is so important, because versus, say, 40 years ago, where you might have an entire ward full of babies with meningitis, we don't see it that often due to decreases in circulating virulent strains of those bacteria. I think, overall, the incidence has decreased. The causative pathogens for bacterial meningitis are the same. And certainly, if you have an unimmunized child, then that index of suspicion should be elevated.
And I've always wondered, sometimes you'll see a kid with meningitis who presents just with meningitis, but often there's some other infection going on that's spreading from somewhere else. Could you comment on your practical experience in terms of other infections that coexist with meningitis when you see the child?
We talked a little bit, and even as you kind of think about the pathophysiology, about meningitis being a secondary bacterial infection that can occur after or within a viral illness. But we also can see meningitis as a more direct hematogenous spread from another infection. And I think probably some of the more likely that we see in the pediatric population would be either arising from a sinusitis, which can then result in direct hematogenous spread into the periorbital space or into the frontal sinuses, and then direct intracranial extension. So you could see that as an underlying pathophysiology. And then the other one that comes to mind would be if you had an acute otitis media that extended into a mastoiditis, and then you had invasion into the intracranial space via that route. So those would be things that I would be looking for on physical exam and also on history. And I would say I have seen in my experience a case of a spinal epidural abscess at the low lumbar spine that was sort of masquerading as meningitis. And in fact, the LP, which I know we're going to get to, was positive. And it was only on imaging that we ascertained that it was actually a spinal epidural abscess. But I would say that that is interesting, but not necessarily frequent.
All right, fair enough. All right, so suffice to say that if you see a child with, say, a cellulitis, that if they're sick, don't just assume that it's just from the cellulitis, that you really need to be thinking about a serious bacterial infection in the blood and about meningitis if they have any of those clinical clues that we were talking about a bit earlier. So it's that classic search satisfice cognitive error where you just stop at the first diagnosis. If the kid is sick, you got to keep on searching. All right. And also, Dr. Camo, could you comment on if a child is already on antibiotics, like let's say they're diagnosed with an otitis media a few days ago, they're on amoxicillin, but now they're sicker, and or if they're on steroids for whatever reason, could you just comment on how that's going to change your pretest probability and how you approach the possibility of meningitis in these kids?
Sure. Yeah. So I do think that's an important thing to be cognizant of. And I think when we think about that, when we go back to that pathophysiology, certainly antibiotics can begin to treat any of those pathogens, really. And steroids can decrease the inflammatory response, which we know is so important in the overall inflammation and the severity of the presentation of meningitis. So you may have a child who is altered or the vital signs are off, but they're not necessarily looking quite as sick as you might expect for meningitis. So I think knowing that they've already had a couple of doses of amoxicillin or knowing that they've had a dose of steroids for any other reason should change your pretest probability such that you have a heightened index of suspicion around something like meningitis.
Fair enough. So there's a lot of things we need to think about in terms of heightening our suspicion for meningitis. There's the classic signs, which the triad is only seen in about 50% of kids. Our suspicion is going to be way increased if they have a petechial rash that's spreading, because the likelihood ratio is like through the ceiling, 37. In the infants, we're talking about bulging fontanelle, but we have to be careful about how we assess for bulging fontanelle because there's false positives there. There's abnormal cry. Remember that nuchal rigidity is pretty rare in the infants, but we should definitely be checking for that in older kids. And that Koenig and Brzezinski sign are pretty useless. And then we need to think about those kids who especially are only partially immunized or unimmunized, especially for the bugs that cause meningitis. And also those kids who might already be on steroids or on antibiotics. That's going to alter their presentation as well. And then looking for other bacterial infections like a cellulitis or a sinusitis or an otitis media, and not stopping there. That if they're sick, we really want to go further and see whether these kids might have meningitis or not. I do want to talk a little bit more about some of the physical exam signs, in particular one that came up in the adult literature, I believe, is jolt accentuation of headache. I always seem to be documenting this in my chart of an adult patient who comes in with headache, whether they have jolt accentuation or not. And I believe that there was a big study in the 90s that showed that it was predictive of meningitis. And, as opposed to Koenig and Brzezinski's, which seem pretty useless. Dr. McPhee, is there any value in jolt accentuation in kids? I mean, we're not going to be doing this in infants, obviously, but in the older kids, is that part of your practice? Is it something that we should be thinking about? Is there more recent literature on it?
Wow, I have to say, it does sound painful, but when you delve into the literature, there was a nice Cochrane review that was published in 2020 that looked at about 1,100 patients, and the sensitivity of that jolt accentuation was about 65% with a specificity of about 70%. I will say that in those studies, they were all combined for adult and pediatric population, and so we don't have pediatric specific data. But just from a practical perspective, for anybody who's ever cared for a kid who's on the sicker end of the spectrum, particularly those with meningitis, it's often hard to just get near them. We often struggle just to get near them to get a stethoscope on the chest. And so I think it's promising, but from a practical nature dealing with kids who are unwell, it may be actually difficult for them to articulate like, yeah, that made my headache worse, because they're likely to be crying throughout almost your entire physical exam.
So suffice to say that jolt accentuation's not very practical in kids, and that in adults, for those of us who thought that it was this fantastic physical exam maneuver that could really give us one strong data point, it turns out, at least according to Cochrane review, that we were wrong, that the sensitivity and specificity is quite poor, actually. All right. The other one I wanted to actually just delve into a little bit more is the neck stiffness, because there are a lot of causes of neck pain and neck stiffness. And again, we're not going to be working up every child who has neck pain or stiffness for meningitis. And there's a big differential, which is an important one. In adults, some of the other really important causes of neck stiffness are a subarachnoid hemorrhage. And as we talked about in our subarachnoid hemorrhage episode, can actually present sometimes with a low-grade fever. So these can get mixed up pretty easily. In kids, my understanding is that retropharyngeal abscess is one of those neck stiffness causing things that can get confused with meningitis. Could you give us any sort of practical clinical pearls about how to differentiate some of the more difficult ones, like, say, retropharyngeal abscess from meningitis?
So I think for me, when I think about the differential between meningitis and a retropharyngeal abscess, one of the important things is that when you have a retropharyngeal abscess, you really don't have that altered mental status. You don't have that change in level of consciousness or anything that's sort of going on centrally with the nervous system. So outside of the high fever, we don't really expect that child with a retropharyngeal abscess to have much in the way of those upper CNS findings that we would see in meningitis. Now, of course, if the fever is up to 40, then you can have a child that's miserable and even delirious by virtue of the fever itself. So once that fever comes down, then try to get a look and see if you can more delineate what's going on with the neck. If the neck stiffness is on flexion of the neck, so bringing the chin down, then that's more consistent with meningitis. And if the neck stiffness is more on extension of the neck, so putting the chin up in the air, then that's more consistent with a retropharyngeal abscess.
Wow, what a great little clinical pearl there. I mean, who knows what the likelihood ratios of those are, but
I credit Dr. McPhee for that one.
okay.
Yeah.
A word from our sponsor, Metricade, the experts on scheduling systems. Since 2015, I've been using Metricade, the incredible self-scheduling system that has made my life and the lives of my colleagues so much easier. Metricade can really help minimize the drawbacks of shift work we all know so well by not only ensuring equitable distribution of shifts, but also integrating circadian rhythm-friendly recovery time into their algorithms. They minimize my sleep deprivation, which allows me to be a better EM doc on shift. I can take better care of my patients and still have energy left after my shifts to enjoy other aspects of my life. Check out metricade.com/EM cases for more details on how this awesome scheduling system works. I want to move on to clinical decision tools to determine the need for LP in febrile infants. To help us with this difficult question of when to suspect meningitis and do an LP, we talked about febrile infant risk stratification and workup with Brett Burstein and Gary Joubert, and the value of CRP and procalcitonin. So when it comes to serious bacterial infection, which has an overlap with meningitis, at least, there are several tools. There's the step-by-step febrile infant decision tool, and that one is the one where you have a well-appearing infant with a negative urinalysis for leukocytes, a CRP of 20 or less, a procalcitonin of less than 0.5. And in that population, there's only a 0.7% risk of invasive bacterial infection or meningitis. So that's the step-by-step rule. Then there's the PCARN febrile infant tool, where a negative urinalysis, an ANC of less than about 4,000, and a procalcitonin of 1.7 or less has a 99.8% sensitivity for serious bacterial infection. And then finally, there's the Aronson febrile infant decision tool, where you use this one if you don't have access to procalcitonin. And this uses temperature, ANC, and urinalysis to help decide on who needs a workup for a serious bacterial infection. So that's what we talked about in that episode in terms of serious bacterial infection, invasive bacterial infection. It all gets a bit complicated because they all have slightly different definitions. Some of them use procalcitonin, some of them don't. But just to give you a flavor of what these tools are like, I wanted to go through them briefly. There's also the Dutch prediction tool to determine the need for lumbar puncture in children 1 month to 15 years of age. So there's all these clinical decision tools. When it comes to pediatric meningitis, Dr. McPhee, what's your sort of bottom line on clinical decision tools? Helpful, not helpful? Do you use them? Don't you use them? Should we just look at what the features are to help guide us, or should we use them religiously like they are the answer to every child who we think might have meningitis?
I think they absolutely have their place. And this is one of the areas of research that many of us in pediatric emergency medicine are watching very carefully right now. Even over the course of my career, I've seen a fair amount of change. And just before I answer your question, I think there are two features that have not changed despite the evolution of many rules. And the first one to remember is that if your infant is ill appearing, they don't fit in any of these risk stratification criteria. And so the sick looking kid doesn't belong in any one of those. So I think that's something that's really important for our viewers to remember. And all of those need a full septic workup, including a lumbar puncture and empiric antimicrobial coverage. And the other thing that hasn't changed is that the definition of fever is 38.0 rectally. And that fever, particularly for young infants, could be present in the emergency department, but it may also be taken at home by reliable caregivers. And so I think that those two things are really important when we're looking at some of those rules. I'm actually quite excited about some of the new research that's coming on in these areas because we do see a fair amount of children who are less than 60 days old who are appearing quite well. And we're moving in a direction where we become more and more selective about which kid needs an LP. And LPs are an invasive test. It causes lots of stress for parents. And quite frankly, we're not always successful in obtaining that CSF sample. And so it causes all kinds of problems. And so we need to balance these kind of risks with getting it right. And so we don't want to delay our diagnosis of meningitis in a really young child or infant because it can have absolutely devastating consequences on their developing brain. So it's hard to get it just right. I think we'll start with some of those rules and some of those centers that have access to procalcitonin because those decisions are much more clear than some of the other ones. And so procalcitonin is an inflammatory marker that starts to rise earlier than either the neutrophil count or the CRP. And as you've outlined in the PCARN study, if you've got a negative urinalysis, an ANC less than 4,090 and the procalcitonin is less than 1.7, then that risk of invasive bacterial infection, and so that includes a positive blood culture or meningitis, is extremely low. And so those authors estimated that a negative predictive value, as outlined by those criteria, was nearly 100% in that situation. And so I think in those centers who are fortunate enough to have access to procalcitonin, they can afford to be quite selective in the number of LPs that they're doing. But lots of centers, including my tertiary care center, we don't have access to that. And I don't think it's a great idea to employ half of the decision-making rule when the consequences could be so devastating. And so that's sort of a start on it. I would say that we have two major organizations, the American Academy of Pediatrics, or the AAP, and also the Canadian Pediatric Society, who have both produced some excellent guidelines in the last couple of years that really attempt to make decision-making a little bit easier for folks who don't have procalcitonin.
Okay, so suffice to say that if you have an ill-appearing child, remember that that child doesn't really fit any of these rules. And so you need to go down the rule out meningitis path. And that we are doing less and less LPs with each passing decade because we are getting a bit better at knowing which kids don't need an LP. And that if you have a procalcitonin, that seems to be very useful in the decision of whether to do an LP or not, according to the PCARN rule. Let's say you're like most of us who don't have a procalcitonin. Are you going to be using any of the other decision tools that don't include a procalcitonin? Or are you just going by Gestalt, or what do you do from a practical perspective?
And so I think most people are using some kind of a clinical guideline in this situation. And to outline the two guidelines that are most commonly used, when you look at the American Academy of Pediatric, it really lumps babies into three groups. So 1, under 21 days, 2, between 21 and 28 days, and the third group is babies who are between 29 and 60 days. And for those authors, babies who were under 21 days were seen as a high-risk group. And irrespective of their blood work, they recommended LP empiric antibiotics and hospital admission for all of those babies. And so that comes from the American Academy of Pediatrics. Their second group was babies who were between 21 and 28 days. And they did use risk stratification that depended upon the urinalysis and inflammatory markers. And those inflammatory markers could have included just the CRP and neutrophil count, so you did not need the procalcitonin. And if the markers were high, their guidance said to get the LP. And if the markers were not high, they recommended a shared decision making on whether a lumbar puncture was necessary. And then in the kids who were between 29 and 60 days of age, no LP was needed if babies met low risk criteria for inflammatory markers. And so that was what our American Academy of Pediatrics had suggested. The Canadian Pediatric Society guideline is a little bit more streamlined, and so all patients are recommended to undergo a CBC with a differential, a blood culture, CRP, glucose, and if available, a procalcitonin. And they break their decision-making into just two groups, so either under 28 days or between 29 and 60 days. And so any patient, regardless of the age group and the under 60 days who does not meet low risk criteria would get an LP admission and a consideration for IV antibiotics. But what happens is the action for the low risk group. And so for babies who are under 28 days, who have low risk blood work, the CPS recommends that these babies are all admitted, but there's shared decision making regarding the LP. And for the kids between 29 and 60 days, clinical decision making is necessary around admissions and about whether the urinalysis is positive or not. And so what we're seeing at this stage is a fair amount of variability from center to center, sometimes from practitioner to practitioner. But the main thing to keep in mind is to take fever seriously in a very young infant, to get a urinalysis and a urine culture on all of them, to get a blood culture on all of these babies, to order the inflammatory markers that your institution has. And when you're making decisions based on those inflammatory markers, you may want to be more cautious with the youngest of these age groups. And so that would be defined as either less than 21 or less than 28 days. And I think there's a real place in here for advocacy. It would be nice to see procalcitonin available in all centers so that we're able to select those right babies for this invasive test of an LP moving forward.
All right. So it's about as clear as mud. Unfortunately, if you look, the American Academy of Pediatrics and the Canadian Pediatric Society guidelines are slightly different. I think it's important to know under 21 days, all these kids are going to get admitted LP, the works. And then between 21 days and 28 days, a lot of shared decision-making will come into play. And then 29 to 60 days, if all your inflammatory markers are reassuring, then you generally do not need an LP. Is that kind of fair enough to say?
I think you've summarized that really well, Anton.
Okay, fantastic. I mean, that's from a practical perspective, I have to say in my emergency department, if I see a child under 60 days, I'm doing exactly what you described, blood cultures, urine, inflammatory markers. I'm just getting the entire workup ordered and literally call for peds as I'm ordering all the blood work, because our lovely pediatric colleagues are happy to see the child and the child will probably require admission. And so for efficiency's sake, and also the nice thing about that is as I call them, I can ask them, is there any other blood test you'd want or any other test you'd want? Do you really want a chest x-ray, etc.? And so everyone's on the same page that way. But there are some of our listeners who are in situations where they don't have access to a pediatric specialist so quickly. And so they're going to have to make some decisions in terms of what to order and when to order it. That's the murky world of workup in the infant. What about the older child? Dr. Comeau, when would you do an LP in, say, a 3-year-old?
Yeah, so I think it does become, I don't know if I'd say easier, but perhaps a little more straightforward. I think a bit easier once the children get a little bit older. And so we can kind of go back to our sort of usual look that we've been talking about and sort of assessing the patient, looking for evidence of fever, evidence for neurologic findings, and that clinical gestalt around, toxic, not toxic, what do the vitals look? So some of the things we talked about at the start of the podcast. So those become really your most useful clinical findings. And we know that once the children are older, they can localize the infection a little bit more. And so the findings really become more focused on the site of the infection, for example, the nervous system.
All right. And in the particular situation where there's a febrile seizure, this question seems to always come up. A simple febrile seizure, obviously they don't need an LP, but when does a child who presents with a febrile seizure require an LP?
Yeah, so I think it still comes back to toxicity, like that look of the child. So any child who appears unwell, who's having a seizure, should have an LP when it's safe to do so. And then I think, you really want to come back to thinking about what are the main criteria to be considered a simple febrile seizure. So that should be a short seizure, less than 5 minutes. It should be a generalized seizure. It should occur between 6 months and 6 years of age. It should occur only once in a 24 to 48 hour period. And it should be in a child who's otherwise developmentally intact. So when you ask the parents, what are they able to do, and they're, 15 months of age, they should have taken a few steps. They should have a couple of purposeful words at least. And so if you've gone through that list of what constitutes a simple febrile seizure and they've met that criteria, they're now in your emerge, they're maybe a little bit postictal or they're fully back to baseline, then I think that's safe to not go ahead with the LP. But anything that's a little bit off when you run through that checklist, or if they're not back to their baseline, I would have a low index of suspicion to do that LP.
All right, fantastic. So the simple febrile seizure, no LP, that one's quite obvious. It's the complex febrile seizures that are kind of a mixed bag. Some of those kids require an LP, especially the ones who aren't returning to baseline after a considerable amount of time. But some of the kids with complex febrile seizures who do return to baseline, who are otherwise well, probably do not need an LP. The next question that seems to come up after whether or not to do an LP is which kids need neuroimaging. Sometimes that question comes up before you do an LP, because if the kid has obvious signs of raised ICP, then at least in the old days, we used to say, do the CT before the LP. But I understand that things have evolved in this question as well. So Dr. McPhee, let's first start with which kids require a CT before LP.
And so very few are going to require CT. And the big thing that we'd like people to remember is that the priority is getting antibiotics in early. And so if you find yourself in a situation where your kid does need a CT, we'd advocate for getting the IV antibiotics started first so as not to delay that aspect of their care. And there are really only two big reasons that you would need a CT in a pediatric patient who you were working up for meningitis. The first is if you were concerned about a space-occupying lesion. And so these are kids that are going to present with seizures, but they're likely to be focal. They're likely not to come back to their normal neurological baseline in between. They may have a focal neurological deficit on their exam. And just as Jeanette was talking about earlier, sometimes children who are immunocompromised can present with incomplete signs and symptoms of various syndromes. And so, a kid with some sort of an immune deficiency may be more predisposed to having an intracranial abscess, for example, and they may have incomplete signs and symptoms. And so I'm much more likely to get a CT in that particular scenario. And the second reason that we might want to get a CT for a child who is undergoing a meningitis workup is if we were worried about raised intracranial pressure. And so if the kid had a Cushing's triad, again with focal neurological deficits or focal seizures, papilledema, which I will say is quite difficult to examine in a sick kid, or is persistently reduced in their level of consciousness, you may wish to get a CT. And the big thing that we'd like people to remember is CT is not a perfect study to exclude the risk of herniation. Herniation would be very, very rare after an LP, and a CT might be helpful, but it doesn't exclude the risk altogether.
The next question that always comes up is the timing of the antibiotics versus the CT if you need it, if you have suspicion for a space-occupying lesion or a suspicion for raised intracranial pressure. So in adults, generally, I will start antibiotics as I'm starting to do the LP. I'll try and do it all sort of together. In kids, Dr. Comeau, any advice as to the timing of antibiotics versus CT if you need it and LP?
Yeah, so this question actually makes me think of a pearl that I got from one of my attendings when I was in training, which is really thinking about antibiotics as a tool for what you're trying to do or what you're trying to determine. So, what she told me and what I tell trainees is we need to look at the patient and think about what is the most important thing right now. Do we need to make a diagnosis or do we need to treat an impending life threatening infection? And so, I would say that if we're trying to make a diagnosis, then the LP before the antibiotics is ideal. But if we have a child in front of us who's rapidly deteriorating, has that progressive petechial rash, for example, then it's much more important that we get those antibiotics in first and we sort of deal with the consequences later, as in we do an LP after the antibiotics. So I do think it depends a little bit on the clinical situation, but certainly we're talking about bacterial meningitis, which we know can be rapidly fatal. And so we don't want to delay antibiotics as we're waiting to get an LP. And similarly, I would say we wouldn't want to delay antibiotics while we're waiting for a CT. And certainly the last thing you want is that overhead call for a resuscitation in the CT scanner.
It gives me great joy to hear an infectious disease specialist say that it's okay to start antibiotics before the LP. Because again, I guess it's in the old days, the infectious disease specialist would be very unhappy down the road after, the second days of admission when they're looking at the cultures and then they don't know what to make of the cultures because the antibiotics were started before the LP, which actually brings me to an important question, Dr. Comeau, of how long generally would it take for your antibiotics to screw up the CSF results, the culture in particular? Because, we're saying that the diagnosis of bacterial meningitis is going to be based on that CSF culture. And infectious disease specialists like yourself really want to know exactly what bug is growing so you can then, use the appropriate antibiotics. So what is the timing like? Like if you give antibiotics and do the LP 20 minutes later, is that enough to mess the results up of the LP? Or is it 3 hours later or 6 hours later? Do we know?
Yeah, so I hope I'm not shunned by my infectious disease community for this answer. So we certainly know that a single dose of antibiotics can sterilize the CSF, both for Neisseria meningitidis and for Streptococcus pneumoniae. There would be other pathogens that are harder to sterilize. Group B strep comes to mind, and E. coli or other gram negatives if we were dealing with that. And then, of course, in the setting where we have a child who's immunocompromised for any reason, we may see prolonged positivity in the CSF with different, whether it's bacterial or viral agents. So in terms of timing, I would say that if it's 20 minutes, we may still have success with the culture. Once we're getting into the range of hours, we may not have success with the culture. But there's more to the LP than just the culture, which again, hopefully my infectious disease colleagues don't mind me saying, but we certainly can use the CSF count, so the white blood cell count in the CSF as a marker, an indicator of meningitis. And the other thing that I think has evolved a lot, certainly over the last decade, is the use of molecular studies on the CSF. And so while you can sterilize a culture in terms of not being able to grow an organism, we can still see evidence of the presence of the organism by PCR methods on CSF after having received antibiotics.
So it's great to know that we have some tests that can circumvent the problem of sterilizing your CSF with antibiotics if that's what you need to do for your patient. When it comes to sending off blood tests for the CSF, there's sort of the standard usual that we send the cell count, the gram stain, the culture, the glucose, and the protein. Is there anything else that we should be on the lookout for in terms of what to send from the CSF in particular situations or in general? I understand that there's CSF lactate, CSF procalcitonin. There's all these other tests that we could send off that I understand might change your likelihood that it's a bacterial meningitis versus a viral meningitis. There's things like Lyme disease. There's HSV. In what situations do you suggest we send off for these different tests?
Yeah, I think it's a good question. And I think it's important to know locally what your own lab can do. And so there are different types of molecular studies that can be done on CSF. And it will vary, I think, from site to site in terms of what's available. So some labs will have isolated PCR for specific pathogens, for example, HSV or enterovirus, whereas other sites may have available a multiplex PCR that could look for up to 20 different pathogens. And this would be common pathogens that you'd see causing meningitis, and they'd be a series of bacterial, fungal, and viral pathogens. And so knowing what's available, I think, is important just in terms of knowing how much CSF to send off. And it's always good to know that before you're in the moment of the situation. So for people who are listening, who are preparing maybe a pre-printed order set, just have an ask with your microbiologist or your infectious disease colleagues to see what is possible. So most places I do understand now have access to some form of molecular testing. And so that would be something that would be additional that I would definitely send off. Other things like CSF lactate and CSF procalcitonin, I have to admit I'm less familiar with using those in the context of ruling in or out bacterial meningitis. But I do know that from a 2019 review, a CSF lactate of greater than 30 to 35 milligrams per deciliter was strongly suggestive of bacterial meningitis. So again, it may be something that's available at your site, but it would be important to find out if your site even has capacity to run these ancillary tests.
I guess the practical take home from that is to always try and get a few extra milliliters in that last tube.
Yes.
To be sent off so that if an infectious disease specialist like yourself sees the patient the next day in hospital, then you can add those tests at a later date if necessary.
Absolutely. Yes.
Okay. Then there's always a situation where you can only get a milliliter or two of CSF. And then you have to decide, okay, what are the most important tests that I need to send off for? I can't send off for, 15 different tests, a million different bacteria and viruses and fungus. I only have 2 milliliters and we just can't get any more out of this infant. What are the most important things to send off from? And that's going to be a decision that the emergency physician might be making in the emergency department, which I'm sure will affect what happens later down the road. So what are the most important, assuming that you only have, say, 2 milliliters to send off?
I think that's another great question. And so I would say the cell count is always going to be important, because I think that can help you irrespective of whether or not you've given antibiotics. And that can also give you information if, you've had a traumatic tap or not. You can kind of get a gestalt of what's going on in there. What you do next, I do think, depends in part on whether or not you've given antibiotics and whether or not you have that molecular panel of testing available. So if you haven't given antibiotics, then I would say a gram stain and culture would be the second test that you would request. And if you have given antibiotics and there's a period of time, say over an hour that's gone by, then you may feel more inclined to go for some of that molecular testing. I do think that this is something that once things have quieted down and you're not actively resuscitating the patient, you could give a call to your infectious disease colleagues just to say, what is it that you think I should do with this CSF?
Okay. So suffice to say that it kind of depends on your patient and the timing of the antibiotics. The last thing I wanted to ask you about in terms of what to send off for, which hasn't come up yet in the podcast, but it seems to be coming up more and more where I live in Toronto, because this particular disease seems to be creeping north with every passing year. And I enjoy time at a cottage north of Toronto. There are tons of ticks. My dog just gets covered in ticks now every time we're hanging out at the cottage a couple hours north of Toronto. And that, of course, is Lyme disease.
Mm-hmm.
When should we be thinking about Lyme meningitis?
So I think you have the right people on this podcast because Nova Scotia has been endemic for Lyme for almost a decade now. It's actually quite prevalent here. I'll take the lab side and then I'll let Dr. McPhee talk a little bit about the clinical, if that's okay. So, from a lab perspective, usually by the time we're suspecting Lyme meningitis, the serology will be positive. So, it's actually the blood test that I would recommend for the patient rather than CSF studies. There are CSF studies that can be done. But I believe, and I would have to check, that they're really a send out to the national lab in Winnipeg. So the timeliness of getting that result is variable. And also, sometimes they require that you've actually got the serology done beforehand. So I would say, in terms of CSF analyses, you'd be doing your routine, your cell count, you'd be doing your culture and sensitivity. That would be negative, which would then push you sort of based on your cell count, your differential of your white blood cells towards that diagnosis of Lyme. But it would be through serologic testing that we would make the diagnosis most likely. By the time you develop Lyme meningitis, you should have seroconverted. And so it is a useful test. Where I'd say it's less useful is when we have like that single erythema migrans lesion. Like, we do not recommend serologic testing because you won't have seroconverted. Conversely, if you have a clinical syndrome that's not compatible with Lyme and then you send Lyme testing, if it's positive, it becomes confusing. If it's negative, people might say they had Lyme anyway. So that's where I think the controversy comes.
Okay, good. I just wanted to clarify
Yeah.
that. Okay, good.
Yeah.
So that makes perfect sense. If you have a kid who's sick enough to be in your emergency department with meningitis and you send off for Lyme, that would be exactly the time when you do want to send for Lyme serology.
Yeah. And you can speak with infectious disease. I think, unlike, say, Neisseria meningitidis, where the timing of antibiotics is really as soon as possible, the course of Lyme meningitis is more indolent. And so while you absolutely want to make the diagnosis and you want to treat the child, you do have the luxury of time to have that conversation to kind of get your diagnostics together and make a plan for what to do with that patient.
Great point. And that brings us to sort of some of the other clinical things to suspect Lyme in. I mean, I guess there's the classical annular rash. There's being in a Lyme endemic region. Dr. McPhee, anything else to add in terms of when to suspect Lyme meningitis?
We practice in an area like the northeastern United States where Lyme has been endemic for many years and have, treated many, many patients with Lyme. Lyme meningitis itself is quite uncommon, even in a population where we're seeing quite a bit of erythema migrans, and we very, very frequently see Lyme arthritis. And when we do see Lyme meningitis, it's often a really indolent course. And so over a series of days, there'll be fevers, there'll be headaches that are on and off, there'll be complaints of neck stiffness. But unlike the other population of patients with meningitis, the vital signs are often strikingly quite normal. The level of nuchal rigidity is quite low. And so it is a fairly subtle presentation that we would really only see based on kind of living in an endemic area. And I think the presence of ongoing symptoms. It would be quite unusual for us to even have that history of a tick bite or have a history of erythema migrans when we're at the point of diagnosing Lyme meningitis. And so it's often in the setting kind of an untreated earlier illness that no one recognized was different from, the viral illnesses that were going around at daycare.
So we've talked about what to send off in our CSF. Let's talk a little bit more about the interpretation of the CSF results. Can you give us some details on the test characteristics of the cell count for pediatric meningitis, and in particular, the degree to which the cell count can help differentiate viral meningitis from bacterial meningitis?
Yeah, so I think the first thing to think about is that the interpretation can vary a little bit by age. So in the youngest infants, so neonates within the first couple of weeks of life, we do tolerate a few white blood cells in the CSF. So counts up to, some literature would say 21, 22, up to 30 would be considered normal in a newborn. So the first couple of weeks of life. Once you get older than that, though, we really expect that the white blood cell count in the CSF would be 0. And so people would say any white blood cells in the CSF is abnormal. When we look further into what the cell count looks like, for bacterial meningitis, we can often see cell counts in the thousands to 10,000s. And that's really because when we think about that pathophysiology again, we've got bacteria that are replicating with really no humoral immunity inside the CSF. And so that replication can take place quite quickly, attracting much more those inflammatory cells, the leukocytes, for example, bumping up that white count really quite quickly. Often you'll see people say, and I think this is probably accurate, that there would be lower white blood cell counts in the setting of viruses. And those can be in the order of sort of, the 10s, 70s, say, or up to hundreds rather than thousands. But I wouldn't say that I would necessarily take a cell count and then say, oh, okay, there's cells, but they're not high enough, therefore it's not bacterial. So while I think it's a helpful thing to look at and be a little bit academic about, I would still be waiting for those ancillary tests. So whether it's the gram staining culture or the molecular tests that you're sending off to fully exclude a bacterial pathogen.
Okay, so you can't really distinguish viral from bacterial meningitis on the initial cell counts, but I guess if it's in the extremes, then that can be helpful. So if you're in the tens of thousands, it's probably bacterial, and if it's close to zero, it's probably viral if they do have meningitis.
Yeah.
I guess from a practical perspective, we just have to assume that it's bacterial and give our antibiotics anyhow, regardless of what the results are. All those kids that you're doing an LP on, who you're thinking about bacterial meningitis, they need to be admitted anyways. So from an emergency department perspective, it's not quite as important. We shouldn't let the white count stray us away from the diagnosis of bacterial meningitis.
Yeah, I think that's the safest approach, is that you're giving those antibiotics and you're putting in and finding a bed for that patient.
Okay, great. Before we get onto the specific treatment, antibiotics, steroids, and all that, I want to talk about how to maximize your chances of obtaining an LP. Again, from a practical perspective, depending on who you are and where you work, where I work, if it's an infant, I'm not doing the LP myself. I'm calling pediatrics and they're doing the LP. If it's an older child, I might be doing the LP myself. I certainly have a lot of experience doing LPs in adults. And, in a teenager, it's not going to be too much different, as an example. But depending on where you work, you might be in a remote community where you need to do the LP on an infant. Can you give us, let's say, your top 3 or 4 tips and tricks on obtaining a successful LP in the infant and in the older child? Dr. McPhee?
I guess just starting out is having a really honest conversation with the family about the lumbar puncture, and that it's a challenging procedure and that you may not always be successful, and having those families be really comfortable with the contingency plan if you're not successful. I feel like that honest approach from the beginning is probably really useful. The second big tip to maximize your success is to keep that kid pain-free. And so there are a number of ways that we can do that depending on the age group, but applying a topical anesthetic such as Amatop or Maxilene may really increase your chances of success. And the use of a local anesthetic such as lidocaine, so 1 to 3 mils of 1 to 2% lidocaine, may really, really improve the success rate of your lumbar puncture.
The days of just giving a little bit of sucrose to the baby and then just going for it, those days are over, I'm assuming?
Those days are definitely over. And so,
okay, good. Because that's the way I was taught in my residency, was give them a bit of sucrose and do the LP.
The sucrose is good too. So I would use sucrose for all the babies, but in the modern care environment, it really is a necessity for you to use some kind of topical anesthetic. If you have the time, so 30 minutes, applying Amatop on beforehand is great. If this is an emergency situation and you don't have time for it to work, then you must absolutely use some local lidocaine.
I'm glad things have changed, because I always thought that was totally crazy, just to give a child a bit of sucrose and think that that's going to eliminate their pain from an LP. All right, sorry. Go ahead, Dr. McPhee.
And I think in that mid-range child or even a teenager, the thought of doing a lumbar puncture is quite anxiety provoking. Some of these kids are really sick and frankly uncooperative. And so if your patient's hemodynamically stable and can handle a sedation, I would try my best to sedate the kid just to maximize your chances of success and hopefully maximize your chance of just going one time or one try for the lumbar puncture more so than anything else.
So that's analgesia. Any other tips when it comes to the actual placing of the needle, the positioning of the patient?
100%. There was a really interesting study called NeoClear, published recently in the Lancet, who did an RCT of neonates who were undergoing lumbar puncture. And they looked at the impact of positioning on the success rate. And so for infants who were placed in the sitting position, the success rates were about 64%. And in the kids who were on the lateral lying position, those success rates were about 57%. And that was a statistical difference. And so I think positioning matters a lot.
Well, so that's consistent with my experience with adults doing LPs, is that my hit rate seems to be way higher if I do it when they're sitting. Sometimes with their GCS of 4, I can't get them to sit. In those patients that you need an opening pressure, of course, you have to do it lying down. But that's kind of a game changer because, again, in the old days, we used to do all the pediatric LPs with the child lying down. So that's a major game changer. So if you're just looking for meningitis and you don't need an opening pressure, then you sit up these kids, even the babies, you're sitting them up. Is that correct?
Even the babies. And so that study that we were chatting about, the NeoClear, was done by experienced neonatologists in an intensive care unit setting. So even small babies, you're going to have higher success if you're sitting them up.
Okay, fantastic.
If you do end up in a situation where you have to do it in a lying position, having an assistant make sure that the patient is staying still is going to be really important. And what you're looking to give them feedback on is we want the hips to be at 90 degrees to the floor as a first thing. And you do want some flexion in your spine. And so your assistant can really accomplish that by placing one hand on the hips and the other on the shoulders. And in particular, it's not necessary to flex the neck down. So I think when you're flexing the neck down, particularly a young child, they're more prone to desaturation, but it's also a really uncomfortable feeling. And the less comfortable they are, the more likely they are to move, and the less success you're going to have. And so no flexion of the neck, just a nice hold at the hips and the shoulders.
Okay, that's another old school thing that we used to do all the time, is try and flex the neck as much as possible. And thankfully, it didn't seem right when I used to do it. And now there's, I guess, a good reason not to flex the neck. So let the child put their neck in whatever position is comfortable for them. Excellent.
I think the other point is really just that difference in anatomy. So the spinal cord in an adult ends at a higher level than it does in pediatrics. And so how that practically plays out is when you're landmarking to do an LP in a neonate, you are aiming for L4, L5 space, where in an adult, you could enter at either L3, L4, or L4, L5. And so that landmarking is different for a child, a really young child.
So when in doubt, go a bit lower.
That's the name of the game.
Okay, got it. That's a great little pearl. All right, so we've talked a lot about the workup of meningitis, the who, the when, and the why. I want to move on now to the treatment and talk about specific medications, with the caveat that local practices may vary depending on local resistance patterns and preferences. We'll have an antibiotic chart with doses in the show notes. To simplify things, generally speaking, the antibiotic choices are going to be ampicillin and cefotaxime in the 0 to 30-day-olds, and ceftriaxone and vancomycin in older kids, just generally speaking. But of course, again, you need to follow your hospital's antibiotic recommendations. What I'd like to ask you, Dr. Comeau, is what other medications, specifically steroids, should we be giving? When should we be giving them? How much should we be giving? And then when should we be considering sort of alternate antimicrobials? When should we be covering for HSV? when should we be giving acyclovir? When should we be covering for Lyme? When should we be thinking about other things? I have had one or two cases over my career where I give all the usual stuff, and then 2 days later I hear, oh, you probably should have given this, that, or the other thing. So in what situations should we be considering more than the usual or different to the usual antibiotic regimens?
Yeah, I think it's a good question. And I completely agree with the antibiotics that you mentioned there for the younger kids and then the older kids. And so if we're thinking about additional antibiotics or antivirals or other medications in general, I think to begin with the antibiotics, there's one additional antibiotic you might give older children or adolescents if they are immunocompromised, and that would be ampicillin in the setting that you're worried about something like listeria. And in that setting, they probably have somewhat of an encephalopathic picture in addition to the meningitis, but not necessarily. And I think when you've got an immunocompromised child in front of you, it's also quite reasonable to maybe call your infectious disease colleagues a little bit earlier just to see if there's anything else that you should rule out. The other group of children that I would say you might want to consider additional antibiotics are, and again, I think you'd probably want to talk to a specialist, would be children who have VP shunts who are coming in having a meningitis picture. So depending on the proximity and the timing with which that VP shunt was placed, they would be at risk of different pathogens as like a surgical site infection. So again, I think that would be a scenario where you might phone a friend. So outside of those scenarios, we've talked a little bit about Lyme disease already. Lyme disease is actually treated well by ceftriaxone, and most studies or sites would say to use ceftriaxone in the treatment of Lyme meningitis. So I think you're fine just with the ceftriaxone that you've started empirically for meningitis. Doxycycline does get well into the CSF space, so it's an appropriate therapy for Lyme, but much easier, just the ceftriaxone is going to cover it. So thinking about HSV, so we know that in neonates, sometimes in that febrile neonate situation, you're going to want to be covering for HSV as well. And so in the neonatal congenital HSV kind of range, that would be up to 6 weeks of age. Neonatal HSV usually occurs within the first month of age, but it can be up to 6 weeks. And so many algorithms will add acyclovir into that workup of the febrile infant. Again, I think it depends on some of those risk factors. It depends if the infant is looking really unwell, if the infant is seizing, the vitals of the infant, I think would be important. And I do think it's important, though, to highlight that the presence of maternal infection is not actually necessarily part of that key diagnostic workup, because we know that the highest likelihood of having neonatal HSV is actually if a primary infection occurred with the mother around parturition, and sometimes there's no lesions that the mother can recall. However, if the mother did have lesions and it was a vaginal delivery, or if she was febrile before, sort of within 48 hours before or after delivery, then that would also increase my index of suspicion and wanting to add acyclovir. I think the important thing when you're adding acyclovir is that you do want to be able to stop it eventually. And so ensuring that you have that CSF that you can send for molecular testing for HSV is important down the road. And I think you've also asked about steroids. So dexamethasone is the steroid of choice. At this point in time, we don't necessarily recommend steroids for neonatal meningitis. And that's because most of the literature around the protection that you get from steroids stems from literature looking specifically at Streptococcus pneumoniae and Haemophilus influenza, which we know are not the bacterial pathogens that are most common in that young neonatal meningitis. So once you're getting into the older children where strep pneumo is still one of the pathogens that we highly suspect, it's relevant to add dexamethasone. Ideally, dexamethasone is given within the first 4 hours of presentation to healthcare. And so I think practically, if you're suspecting bacterial meningitis, you should be giving dexamethasone early and upfront. There is literature that suggests you wait and you see if you get a gram stain, and then if the gram stain is positive, then you would go ahead and give the dexamethasone. But I think that you may be missing the boat if you're waiting around for the CSF to come back. So I would say you would give the dexamethasone upfront in the setting of bacterial meningitis.
Fantastic. Okay, so the bottom line there is give dexamethasone in all kids except neonates within 4 hours of administration of the first dose of antibiotics. We used to think, we need to give it before, but no, we want to give the antibiotics first.
Mm-hmm.
And then as long as it's within 4 hours, we're good. I guess the earlier the better.
Yeah.
Then with regards to other antibiotics and things to think about are you might want to give ampicillin if the patient's immunocompromised. VP shunt is another population that might require specific antibiotic changes. And then adding acyclovir if the child is 6 weeks or less. It's something you might want to pick up the phone quickly to your infectious disease specialist or your pediatric colleagues if your patient falls into one of the 3 categories of immunocompromised, VP shunt, or neonate. Is that a fair?
Yeah, I think that's fair. And both the AAP and the CPS guidelines have a few bullet points on who would be that kind of population that you'd worry about with the neonates for adding acyclovir. So if a neonate has seizures, no need for a phone call, add acyclovir. If you do have that story where the mom actually had genital lesions and that was the first time at the delivery, just add it. But if you're on the fence, give a call.
Totally reasonable. Excellent. All right. I'd like to now go back to the case that we talked about at the top of the podcast. Let's say you've stabilized your patient. They've got some antibiotics on board and the LP's been done, and you're waiting for transfer to a pediatric tertiary care center. Let's say you're working in a hospital that doesn't have pediatrics. Dr. McPhee, first, what are some of the complications you need to be on the lookout for and ready to treat? We've talked a little bit about seizures. What kind of things do you want to monitor for in your child who you're quite sure has meningitis and you're waiting for transfer to a pediatric center?
This is a kid that's going to require close supervision with a high nursing to patient ratio as you're waiting for that transfer. And if you think the transfer is going to take a while, I might order some routine labs, really looking to make sure that the patient doesn't have a low sodium, so not getting into an SIADH picture. I'm going to make sure that my glucose remains stable. These kids with meningitis are at high risk of having seizure. And so in the back of my mind, I might want to write a rescue dose of a benzodiazepine in case the patient does start to seize. So having all of these things ready and thinking about them as you go along would be really important. And I think just, making sure this kid is on monitors and that you're really fine-tuning any hemodynamic support. So whether it's fluid or pressors, we really need to, have a close eye on those things as well.
Fantastic. If you can anticipate what the complications might be, it's just so much smoother and better when they do occur if you're ready for them. Excellent. And Dr. Comeau, let's say you're the accepting physician at the tertiary care center. What practical things are you going to expect and hope for when that patient is transferred? Like, do you have sort of a checklist that you will ask the transferring physician? What kind of things do you want to make sure have been done to ensure a safe transfer?
Yeah. So I think for me, if this patient, the initial workup has taken place elsewhere, certainly from that infectious disease standpoint, if the LP has been done, then I absolutely would want to know what happened with the CSF so that we can follow it, so that we'll get that information, like anticipating that, if the gram stain was to be positive, we could get that information. If it's going to be sent out for further testing, where would that come from? In terms of the patient themselves, if they've done everything we've talked about in this podcast so far, then that initial workup has happened in addition to the initial therapy. So they've got their antibiotics on board. They've got some steroids on board. We're actively looking for any complications, and we're able to provide therapy in that event. And the recess has already happened. So I think what I'm going to be looking for going forward is making sure that we have all the timing right. So the next doses of antibiotics are given at the right time, making sure that we have the workup done so that we can continue seamlessly with knowing, what information we have available as we go forward. And then there are a few infections that, if it ends up being Neisseria meningitis, then we're going to need to be talking to public health because we're going to need to look and see, are we going to need to give prophylaxis to the family or other people who've been in close contact with them?
I have to admit, that's a point I never thought about. Excellent. Well, we're coming near the end of this podcast on pediatric meningitis. Any other words of wisdom when it comes to this topic that you'd like to leave our listeners with, Dr. McPhee?
Pediatric meningitis these days is not as common as it's been in the past, but keeping this high on the differential so that you don't forget about it and can act quickly when it's there, I think would be really important. And I guess the other thing is that there can be a sneaky presentation. So sometimes children with meningitis can get sick, and they can get sick very quickly. But a more common story is that there's an interval worsening in the setting of an ongoing viral illness. And so just being really alert for those changes that are occurring really suddenly in what looks like the middle of a viral illness.
Excellent practical pearl. And Dr. Camo, any other last words of wisdom when it comes to pediatric meningitis?
I would absolutely echo what Dr. McPhee has said in terms of the decreasing incidence over the last number of decades. And I would caution that in the infectious disease community, we are worried because in 2019, the percent of the world's children who were vaccinated was 86%, and that has decreased now to about 80%. And so coming out of the pandemic, we have seen a decline in uptake of childhood immunizations. And so that actually is the sort of the big fear that we're going to see some of these illnesses that we have really, had a diminishing incidence of reappear. And so meningitis, being caused by Haemophilus influenza, Neisseria meningitis, and Streptococcus pneumonia, all of which we have vaccines against, may be something that's on the rise. So I think it's something that we need to think about in our practice and be sort of aware of as we move forward. The other pearl that I would say, and you actually highlighted it in the case, is that I would worry about a secondary meningitis or bacterial infection in any child who's been sick for a period of time, seem to get better, and then get sick again. So that new fever, that new illness can be the first sign that there's actually a new bacterial process going on. So that detailed history of that period of time where they were well is incredibly important in making sure that we don't just sort of say, this is another viral infection from daycare, you can go home. Because that's the worry, right? We really want to figure out which child is fine and can go home and which one we need to do that additional workup.
That might be, in fact, the most important fact about this podcast is the notion that we are likely to see more and more pediatric meningitis. And that's really the key, because we might have been lulled into a sense of complacency, thinking that kids who present with a febrile illness, who are more than just typical viral illness, I have to admit that, 10 years ago, pediatric meningitis was way at the bottom of the list because I had hardly seen a single case in a decade. But we should anticipate seeing more and more of these cases, given the decrease in vaccination rates across the world. So I think the timing of this podcast is quite important, and I hope our listeners are left with a much more clear picture of who they need to work up, when they need to work up, how they need to work up, and how they need to treat for the possibility of pediatric meningitis. So thank you both very much for your expertise on this topic. I hope we can have you back on EM Cases someday.
Thank you.
Thanks, Anton.